Good morning. Welcome. We're so glad you're here today. I am here with my co-chair, Meredith Land, and Meredith and I chair the National Advisory Board for the Laura Bush Institute for Women's Health. And we have a great program today and hope you enjoy it. And I want to wish a special welcome to Laura Bush. Thank her for being here. I know that's why you're here.
So happy to see you all, and Mrs. Bush. We are so happy to welcome you. This is the 8th annual Laura W. Bush Institute for Women's Health Coffee and Conversation. I love these. Each year we bring you really interesting information that can make a difference in your life and those that you love, their lives as well, their health. And the presentations this morning are relevant to every single woman in this room. And I'm certain that you'll be so glad that you came, so thank you. We are grateful for the underwriting for today's Coffee and Conversation. It has been provided by members of our National Advisory Board, and we'd love for you to stand up, members of our National Advisory Board, so we can recognize you for all your contributions. Thank you. Jean Cox and Jan Reese-Jones underwrote this program this morning. Thank you so much. To begin our program, I want to validate our topic today with a statement from the National Institute for Health, Office of Women's Health. It says, today, women are understudied, underdiagnosed, and undertreated. We are so fortunate to have with us two distinguished physicians and scientists who are national leaders in the field of women's health. Marjorie Jenkins, MD, is the founder of the Laura Bush Institute for Women's Health and a member of the National Advisory Board as well. She is Dean of the University for South Carolina's School of Medicine in Greenville, South Carolina, and the Chief Academic Officer for Prisma Health Upstate. Dr. Jenkins has many books. You must read them. She co-authored Eat Like a Woman, co-editor of How Sex and Gender Impact Clinical Practice, an evidence-based guide to patient care, and co-author of a new book recently published. We got an advanced copy yesterday. I've already started in on it. Why Women Aren't Winning at Health, but Can. Dr. Alyson McGregor is the Associate Dean of Faculty Affairs and Development and Professor of Emergency Medicine at the University of South Carolina School of Medicine, Greenville, and co-founder of the Division of Sex and Gender and Emergency Medicine at the Warren Alpert School of Medicine at Brown University. Dr. McGregor is the author of Sex and Gender in Acute Care Medicine and Sex Matters, How Male-Centric Medicine Endangers Women's Health and What We Can Do About It, and co-author of Why Women Aren't Winning at Health But Can. These two know each other pretty well. And they are going to put on a good presentation for us today. I want to welcome Dr. Jenkins and Dr. McGregor to the stage. Thank you.
It is really exciting to be here with one of my almost lifelong friends and colleagues and co-authors. And I just wanted to start out with asking Dr. McGregor to talk about her journey and how she became one of the international experts in sex and gender medicine.
As was mentioned, I'm an emergency medicine doctor, and I've been practicing as such for almost two decades. And when I started to really learn, and I was coming out of residency and I'm seeing all these patients, I felt very, I had this unique perspective of health and disease because I could see the entire spectrum. I mean, if it can happen, it comes into the emergency department. And I also saw the bias that women undergo, the eye rolls that will happen if a woman's calling out for pain, the sheer number of diagnoses that they have with that end in the word syndrome. You know, that's not really a diagnosis, right? And just the sheer number of prescription medications that they're taking to combat the side effects from the prescription medications that they're taking for that syndrome. And I thought, this is important, and I started to explore this bias in our health of women. And both Dr. Jenkins and myself came across the book by Marian Legato, Gender-Specific Medicine. And I was reading that and thinking, we all need to know this. We are different than men. And so I went to a national meeting for the emergency departments, emergency medicine, and I put together a program, and I was going to have a didactic, and I showed up, and nobody else did. And this was 18 years ago or so. So then I looked around and thought, well, emergency medicine is certainly not ready for this, but I have to go find like-minded women. I need to create a community around this. And so I went to the American Medical Women's Association annual meeting. It was the first time I had ever gone. I was there by myself, and I started to talk to other women and realized that we have something here. And so that began the Sex and Gender Health Collaborative. That's when I met Marjorie. And it was wonderful because we were a collection of women in all different specialties. So internal medicine, emergency medicine, obstetrics, cardiology, orthopedics. And we really said, okay, this is something that we need to explore, and we need to start creating evidence. And then I went back to my home state at Brown University, where I was practicing, and I decided to really focus my research on that. And I developed a division of sex and gender and emergency medicine with electives and fellowship program, where we graduated women who are now well equipped to study this and to carry on this research. I'll stop there. I'll let you in.
Yeah, that's great. And then I worked on her for 2 years to get her to my medical school, and caught her on a bad day at Brown and said, come on down to Greenville, South Carolina. So I started out as an engineer, so I'm a data person. And I was in practice for 3 years. I'm an internal medicine physician. I'm a womanologist, really. Because when I would tell people I was a women's health physician, they wanted me to deliver their baby or take out their uterus. So they wanted to use it or lose it, and they wanted me to help them. And I don't do any of that unless it's on the side of a freeway and the baby's coming out. So I saw just in my private practice for 3 years in Cincinnati that men and women really do communicate differently with their physician. And my practice was 75% women and 25% men. And I just started noticing these differences. And I also did not love sending my women out to the OBGYN for hormone therapy treatment, because internal medicine is not really taught to take care of women during the menopause transition. So fast forward to Texas Tech University recruited me to build women's health programs between OB, family medicine, and internal medicine. And that was great. And then my chairman at the time, who was sort of a stick in the mud, he didn't understand why I would just want to see women. Like, how are you going to do that? I said, if a woman calls and needs a new patient appointment, put her with me. If a man calls and asks for an appointment, put him with someone else. Like, this seemed very like ABC to me. So Marianne Legato at Columbia wrote the first book of sex and gender-specific medicine. It was 900 pages. I read, it's a very heavy, research-heavy textbook. I bought a copy, I put it on my bedside table, and I read it over the first year. This was in the early 2000s. So I took that book into the dean, and I said, I'm never going to talk about women's health again. And he said, well, that's why we hired you. I said, this is the best kept secret in medicine, and we can do better for women. And that's really, Alyson and I say we're groupies of Marianne Legato. She's like the grandmother of sex and gender in the U.S. And that really made us embark on this journey, which has now encompassed almost 2 decades. And it is amazing to see the Laura Bush flourish. And I was just talking to Angela Knapp, the senior director of the Laura Bush, and we were talking about the numbers of people that have been impacted by this institute. And when we asked Mrs. Bush for her name, the only thing she said, I want you to help women and girls in Texas. And I think we have done that. But because I was the executive director of the Laura Bush Institute, guess who took my calls and answered my emails? When I was Marjorie Jenkins, associate professor of internal medicine, and I'd email someone, they might or might not email me back. But when I said, hi, I'm the executive director of the Laura Bush Institute, oh, I can talk to you today. So really, just the name of someone who's so revered and respected, who's such a champion for women all over the world, really gave us a leg up and helped spur all of the work we've done in teaching a new generation of physicians. So that's really where we come from and why we're here. And we do have a few prompt slides, I think, to talk about some topics that we thought you might want to hear about. And then we really want to leave a lot of time for you to ask questions of us and also to dialogue with your fellow women in the room. I mean, we really want to hear from you. So we'll start with 30 years ago, the NIH Revitalization Act, and we overturned the FDA mandate that prohibited women from participating in research. So Alyson, may I call you Alyson?
Yes, please. I think one of the most significant pieces to understand is how we got here. Why do we live in a world with this bias against women and their health? And it dates back to how human subject research was first started. And because of some, very necessary regulations that needed to be instilled just for human protection, human subject protection, and informed consent, and going through an institutional review board, all of that became established around 1973. And at that same time, they labeled women as a protected subject. So first it was pregnant women, and then it was, well, if they're lactating, then we don't want to research them. And then it was, well, if they can get pregnant, so any women of reproductive age. And then it just became, well, let's just exclude women. And so that was really the time that we started our major evidence-based medicine, our cardiovascular trials. The Physicians' Health Study is our major trial that gave us the understanding today of what we think of when we think of coronary artery disease. And that was a study that enrolled 22,000 men. So the NIH Revitalization Act was around 1993, and it overturned that. So this was very significant, and this had to do with the women's movement at the time. They said, we don't know anything about women's health outside of their reproductive bodies. And so with that revitalization, it at least marked an official acknowledgement and a change. But as we all know, that it takes so long to really make a difference. So much of our basic understanding and knowledge was on male animals and male humans. And so it's hard to all of a sudden ask that researcher to switch and, oh, now include women. And now we realize it's more than just sprinkling a few women into the study. We now need to analyze the data separately so we can look and really reveal any important differences that there might be. So this is 30 years ago, and so lots of different organizations are celebrating this now, and we thought this would be a good way to just bring that up and get it started.
And I'll speak to the FDA because I did work at the FDA for 4 years until 2019. I went there for 1 year to try to go behind the curtain to find out why the FDA wasn't really studying women and yet approving medicines and devices that we had to be treated with for life, threatening illnesses. And they said, well, come and work for us for a year and do some research and health policy work and help us understand sex and gender. And it lasted 4 years, which should tell us not to trust the government. So it was a phenomenal 4 years. I learned a lot. I learned about health policy writing. I wrote health policy. I wrote FDA guidances. I learned why they put words in there like should, could, might. Because you know what those words do? Nothing. They don't make people do anything. Because it says you should study women. You might study the data separately. You could publish the data and outcomes by sex and gender. And at the end of 1990 to 2015 of the NIH, the audit reports say exactly the same thing. The only thing that changed was that in 2015, 60% of study subjects were women, but we weren't getting any answers. So it's one of the congresswomen who really helped spur the Centers of Excellence in Women's Health said it's like when I go to the store and I tell my teenage son to change out the laundry and put it in the dryer. And I come home and I'm going to fold the laundry and I open it up and it's still soaking wet. And I say, didn't I ask you to change out the laundry? And he goes, yes, but you didn't tell me to turn on the dryer. So we got so far, and then we didn't turn on the dryer. So that's really, and yet we have some information today on some really important areas that we can tell you have been studied. Of course, cardiovascular disease is that signature disease. The Red Dress campaign of Mrs. Bush was the global ambassador. I think you were at New York Fashion Week, weren't you? And walked into the tent, the red dress, and then she became the ambassador about heart disease for men and women. I've heard the testimony of women who tell me that Mrs. Bush saved their life because they heard her speak. And so we do have a lot of progress. But let me just tell you, for 30 years, now the new hashtag is 3 not 30. And I'm like, what are we going to change to get there in 3 years when we've been working at this for 30 years? And so we want to get that across to you today. What can we do? What can you do to be advocates and champions and help us move this needle? Because we give $49 billion of our tax dollars to the NIH, and we are 51% of the global population. And it ticks me off that my tax dollars aren't really helping me out at the NIH. So that's really the basic premise. So I do get a little fired up about this. Do we want to say anything about? Okay, there you go.
So, I mean, how many of you have heard, women's health be referred to as bikini medicine? Probably. Oh, okay. Yeah, interesting. So, because most of our research was done on men, and we, apply that to everybody, we really couldn't study menstruation and giving birth and menopause in men. So that was really the only thing that we then went and studied in women. And it became, sort of this concept that women's health is reproductive health only. And which siloed all the efforts to providing medical care for women into only those issues. So when you think about it, heart disease is the #1 killer for both men and women. But women are less likely to go seek care. They're less likely to receive evidence-based medicine when they actually do go to the emergency department. And they're more likely to die leaving the hospital than if they were a man with heart disease. And that's because we have this concept that the old paradigm that women don't have heart disease until they're postmenopausal. And that's just not true. We've used this understanding of the mechanism of heart disease in men as the baseline for our understanding of all heart disease. And women have different risk factors than men. Did you know that if you have, while you're pregnant, you have gestational diabetes, or you have, intrauterine growth reduction, or these things are risk factors specific to you as a woman for heart disease in the future. And so there's this real need to look at how we are functioning in a full system. We are not just our boobs and tubes, which I've heard said. And so I think it's really important to just understand that. And so one of the things that Marjorie and I really try to advocate for is that, changing that concept, changing that gut of women's health must be OB-GYN. So that's that first sort of change. One of the things that the NIH, I sit on the advisory committee for the Office of Research on Women's Health. And the director there, Janine Clayton, she has really tried to change the way that we say it. So instead of women's health, it's the health of women. Just to make that new mental model of things beyond the reproductive system.
So I mentioned in my introductory remarks that, I wanted to take care of the whole woman. And transitions from puberty to reproductive age, and reproductive age to menopause, and menopause to maturing as a woman, all of those carry with them very specific health issues that you deal with. For instance, migraines. Boys have migraines far more frequently before puberty than girls. And then when we start our cycle, then women have more migraines. And when we're pregnant or of reproductive age, we basically, some women think that is what they're doing between 20 and 40. They're starting their family, or those women that choose to do that. But there's so many more things that can go wrong. And that multiple sclerosis happens more often in young women and girls. And if you think that our brains are the same, why are the majority of MS patients women? There's reasons for that. And you move into menopause. And what Alyson said about gestational diabetes or hypertension of pregnancy or preeclampsia, they portend your risk of stroke and cardiovascular disease after menopause. And yet, what woman in here who is over 50, I'm 55, have my doctor ask me about my pregnancies? My kids are 24, 26, and 28. Has any doctor asked you, do you have hypertension? Just good, stay with that doctor. Because that is important information for us to know. And also this thing about menopause, and we're going to talk more about menopause, so I'm not going to let the cat out of the bag, but this sort of basket that we throw everything in, it must be menopause. Oh, I just had a menopause moment. I mean, that is a way out of really digging deeper to understand why we can't remember what we went into the kitchen to get. And we say, oh, it's just menopause. Or when we have urinary issues and we go, oh, it's just aging. That's not true. And as women, you should be empowered to know that and to demand answers on how you can keep your body and your brain and all your organ systems really healthy. So next.
One other additional comment on that is that when I think about medical education, I think about my, my high school biology class, right? We get told the story of the sperm and the egg, and that they decide whether we get XX or XY chromosomes, and they then decide whether we get ovaries or testes, and then estrogen and testosterone, right? That gives us hair growth, breast growth, voice changes, secondary sex characteristics, we call it. And then that's it. and then they're done, right? We just ignore all of that. And it's amazing how we're discovering how important all of those differences are. But when I think about my medical school textbooks, I think about my anatomy book, and it was all pictures of men, male anatomy, and then there was the insert of, oh, here are the ovaries, here's the uterus. I was looking at a pathophysiology book a couple weeks ago, and it's the same thing. And it was like the endocrine system, and it was this white man standing there, and all of his endocrine organs were colored, and there was a little box. Oh, women have a uterus and the ovaries. So that's why, that big concept of really us being reduced to just those things are really, it's dangerous. And so how many of you know the example with Ambien and Zolpidem? Great, more and more I get so excited when someone raises their hand.
This is Mrs. Bush's hometown.
Yes, okay.
They know Zolpidem. But it's important to hear the story because it really does impact the thousands of meds. So.
Yeah. So this is one medication that was on the market for over 20 years, and it's a sleep medication, and it was studied in men and prescribed mostly to women because women are the ones diagnosed with sleep disorders more commonly than men. So all these women are on Zolpidem, and what happened was there were post-market surveillance reports because that's all we get. If we weren't part of any of the series of the studies, of any of the clinical trials, and then the drug is approved and it's being prescribed, all we get are the ability to write a report, to say, I think I'm having this reaction. Patients can, doctors can, pharmacists can, anyone can. So there were thousands of post-market surveillance reports of women waking up the morning after taking Zolpidem and getting in the car and having impaired driving. So with that, there was this quest to look at this a little bit. And so there was a new formulation of the drug. It has smaller half-life. And they said, well, let's look at this, let's study this. And they gave it to men, and they gave it to women, the same dose. And then they put them in driving simulation studies, the same studies we use to determine blood alcohol level in driving. And the women were crashing the cars. And so the scientists then grabbed serum concentrations, grabbed blood from the men and the women, and they found that the women still had 2 times the serum concentration left in their blood compared to men. So given same dose, same time, metabolism is a lot slower. So we're overdosing women. And this was the first FDA sex-specific drug dosing recommendation. And women are now instructed to be started on 5 milligrams and men 10 milligrams. Now, I see a lot of people's medication list, and I can say that that's not something that I think is commonly known. But what really frightens me is that that's one medication. Right. There are over 20,000 FDA-approved drugs right now. And so that is, again, these are critical differences that need to be embraced and unapologetically.
So I think the 3 milligram, take it every morning. That's terrible. Who wrote that? Deb. Yeah. So that's malpractice. I mean, so I actually talked to the lead approver of Zolpidem when I got to FDA. I was just like a little detective. I was talking to people and trying to figure out why these things were happening. And they had the data. They had the data back in 1990s when they approved this medicine that women had twice the level in their bloodstream, but they didn't know what to do about it. And so they didn't do anything about it. And another example of medications, do you know anyone in your life that has gotten pregnant while taking an antibiotic? because it interfered with their birth control pill? Yeah, that's a big no-no. I mean, really, you're on birth control, you take Zithromax, and you wind up pregnant. Now, doctors should tell women you should use 2 forms of contraception during the time you're taking these medications. How about the young teenager with seizure disorder that has breakthrough seizures? And what do we think about teenagers? They're forgetful, right? So she's not taking her medication correctly. Actually, it's because of where she is in her menstrual cycle. She's breaking through on the same level of medicine, but she's getting browbeaten by her physician, and her parents are probably listening to the doctor, and she's saying, I'm taking my medication. These are things that need to be known. Women are being harmed by that. That young girl is having breakthrough seizures. She can't drive when she has a seizure. She can't drive for a year. And she feels psychologically abused because she was told what she knows she's doing. So basically, there's many examples like this, and part of our work in educating physicians and pharmacists and nurses is really understanding why these examples, matter, and that doctors should know this and be able to talk to their patients.
Back to that high school biology class. When I think about that now, and I think about the organs that we have, which has our DNA in it, which has our sex chromosomes in it, they're still doing things. It's not over because we now have we're born, or have our ovaries, or we have our hair. It's these chromosomes are in every cell in the body. They're in the heart, and they're in the coronary arteries, and they develop plaque differently whether they're in a woman's heart or a male's heart. They're in the heart muscle. I was taught heart failure was just one type of heart failure. Now we realize that there's many different types of heart failure, and there's heart failure that happens to men, and there's a heart failure that happens to women. And it has to do with how those chromosomes in those heart muscle cells are reacting to high blood pressure, right? With men's hearts, they get floppy and large, so they can't squeeze. Women's hearts get concentric, so they get stiff. It still results in failure. It still results in the fluid not moving, but these are everywhere. They're in the liver, as we talked about, with metabolism. There are over 1,000 genes in the liver that have now been shown to have sexual dimorphism, which means just difference, whether you're a male liver or a female liver. 1,000. They're in the kidney, and they affect the excretion of drugs. Men excrete, Tylenol, beta blockers, benzodiazepines much quicker, but we don't take any of that into account when I'm looking at my up-to-date or my Hippocrates, when I'm writing prescription medications. No, it's not part of the decision-making process, although it should be. And they're in the stomach lining. Women have slower gastric emptying times. We have longer intestinal transit times. Those chromosomes are in the lungs. Women with lung cancer are more likely to have it not associated with smoking. And if you are a smoker and you're a woman and you stop smoking, you heal quicker than if you were a man that stopped smoking. This is all at the cellular level. It's in our brain. That DNA is affecting our brain anatomy and our neuropsychological development. So really embracing the fact that we are different from the cell on up. It's a lot bigger than we thought.
So hormones. Oh, I get the hormone picture. This is awesome. We have learned over the last 20 years that your ovaries are still doing work for you after menopause. It used to be that we would go through menopause, and we thought the ovaries just stopped working. Perimenopause is about 7 years around the time of menopause, when your cycle gets irregular. I likened it to the car I owned in high school, where during the winter it might start that day or it might not start that day. And that's about what the ovaries start doing in perimenopause. But menopause hormone therapy, we also, back in 2001, with the Women's Health Study about hormones, remember when it was, they caused breast cancer and they caused colon cancer, and women were just flushing their estrogen down the toilet and getting through hot flashes. We now know that hormone therapy has a lot of benefit for women. And if you take it at the right time and the right dose for the right reason, it does not cause all of these terrible adverse events. In fact, women who have been on hormone therapy for longer than 10 years, their breast cancer risk goes down. The bad player in hormone therapy is actually medroxyprogesterone. That's a synthetic progestin. And so we now know teaching with micronized progestin is healthier. If you still have your uterus and you're taking estrogen, you need to take progesterone. So prometrium, or micronized progesterone, is probably is better, the research shows. In talking about how we get data, there was a study in men out of Emory University back in the, I think, 70s or 80s, and they gave them all of these different meds to try to prevent heart disease because they didn't think women got heart disease. They actually gave men estrogen to see if it prevented heart disease. So that's how this pipeline sort of works for us. But I do think that as women go through this menopause transition, my patients used to tell me in my 30s I'd understand better when I went through menopause. I mean, I was a good doctor, but I didn't really understand what hot flashing every second felt like, or waking up with sweat. And so I've been through menopause, and I do understand it better. And it made me even more dedicated to helping guide women through menopause, whether they need hormone therapy or want hormone therapy, and how we talk about that. And how we try not to talk down to women who come in and ask for compounded hormones. When I started practice in Texas back in '01, I must have gotten 5 copies of Suzanne Summers' book about hormones. I'm like, Suzanne Summers, Three's Company, really? You want me to read her book? So, but so I think for women here, whether you're before menopause or you're perimenopausal or after menopause, or you're still on hormones after 10 or 15 years, that may be okay for you. And that is also personalized medicine. And so I had an 80-year-old lovely lady come in and said, I want you to be my new doctor. I said, I'm happy to do that. Why did you leave your other doctor? Because he wanted to take away my hormones, and I told him he would have to pry them out of my cold, dead hands. So I kept 80. Why would you want to take a woman's hormones away at 80 years old? So, this is a very important topic to us. Alyson and I don't neglect the reproductive organs and the bikini area, but that's not who we are as women. That's not the totality of who we are.
And look at that figure. It's showing the difference between the luteal phase and the follicular phase. And when we think about, I had this thought just the other day, like we talk about the menstrual period. And it's like, okay, the bleeding part, yes, okay, that's visible, but there's a whole cycle that's happening, and it's not just happening in the uterus or the vagina, right? So we have receptors for estrogen in every single organ, in our brain, even in our immune cells. So I think it's important to think about the things like how estrogen affects metabolism of medications. We should be honoring that and changing your doses of your medication during these 5 days, instead of just increasing that seizure medicine for every day of your week. Estrogen affects our perception of pain, our cerebral blood flow. That's why we have migraines during these times. So this cycling that occurs, again, has just been siloed to the reproductive, issues, and that's why we advocate for just the whole, to really embrace this, to have crosstalk between specialties, because it seems like, okay, I've got these organs, but putting them all together is really important for women.
I'll start with this one, with the Preglock task force. So when I was on when I was at FDA, the commissioner selected me to be his representative on a congressionally mandated task force for research in pregnant and lactating women. And I was not officially a contractor. I was a contractor for the FDA. I wasn't really employed by the government. I was still employed by Texas Tech. And people kind of wondered, why did the commissioner pick an internal medicine physician to be his proxy on a task force? And the reason is because people have territory in organizations. So there are different centers and different offices, and they own this. So we own maternal fetal health here, or we own that. And he knew that I didn't have a dog in that fight, and I would just bring the experts to the task force from the FDA for them to try to understand why we were protecting women from research instead of protecting women with research. Do you know that 68% of pregnant women take medications during their pregnancy? Just because they get pregnant doesn't mean they don't have high blood pressure, get sick and need antibiotics. So I had to kind of build my reputation on that task force pretty quickly. And we had advocacy groups there, we had Big Pharma there, we had NIH, CDC. And so I said, who remembers the pregnancy labeling? We have mommy meds, right, at the Laura Bush Institute and the Infant Risk Center. So there's an app you can download, Mommy Meds, and you can scan the medicine, and it'll tell you whether it's safe in pregnancy. And and there's one for physicians as well. But we had the ABCD, remember on your label, on your medicine label, A is fine to take, B is probably okay to take during pregnancy, C, we don't really have a lot of data, D, don't, and X, never. They changed that labeling within the past 7 years at the FDA, and they changed it, and now they just put a lot of content on that label. Now, have you ever tried to read a label? I mean, it's microscopic. And so now it's really useless to physicians. But I said, I'm going to take the first 517 medications that have been changed over to this new label, and I will report back to the task force whether there was human data in that label. Well, I can tell you that my colleagues at the FDA were none too thrilled that I promised to deliver that data. But we did, Senator Collins also requested it via a letter because there was some pushback. So we started doing that inventory. I needed to present it to the task force. This was a year-long task force. I got permission to give the data to the task force 5 minutes after the last meeting when we had voted on recommendations to give to the Health and Human Services Secretary. So they thought they got me. They thought this won't go in that task force report. But I had made some friends at NIH, and so I went and spoke to them, and I said, let me write a paragraph and include this as an appendix, and could we have them vote by email to include it? Because of those medications, 72% had no human data in pregnancy or breastfeeding. 72%. And the rest weren't rigorous studies. They were case studies. We heard about women coming in that stopped their MS meds because they wanted to get pregnant and they didn't want to lose the baby, and their multiple sclerosis relapsed, and they never went back to walking again because they were afraid to take that medication. We heard many, many stories from women about that. So I think when we talk about the pregnancy gap, Big Pharma, who sat at the table, said they would not study women because of liability. All the way through, it's not just the mother, but the baby, all the way through to college. So if they didn't get into Harvard, they could be sued. And so we have a real issue here about giving women medication in pregnancy and finding the answers for them. It's going to take tort reform. It's going to take federal tort reform, not state by state. And as a pregnant woman right now, I mean, it is scary out there. And one of the best resources in the world is at the Laura Bush Institute, and that is the Infant Risk Center. And I'm so proud of that work that Dr. Hale and Dr. Baker have built, because pregnancy is scary enough. And when you have to take something to save your life or prevent a stroke, and you think it's going to harm your child, that's a big decision to make. And women, we put everybody before ourselves. So women are stopping life-saving medicines.
And when they got rid of the letter system, what we have now is just a registry. So just like post-market surveillance, pretty much. They want you to tell them if you had a bad experience, and then they'll use that to maybe change or approve the new drug. So I think that we've sort of risk averse with pregnant women, and we just make it all her problem. You decide whether you want to take that migraine medication, right, or your MS medication. I also feel the same way about studying vaccinations. So when we were in the crux of the pandemic, I had a friend connect me to someone in one of the pharmaceutical companies that were having the first two major vaccines, and I said, you had to get one, and then of course a little bit later get the booster. And I said, well, are you enrolling pregnant women? And they said, no, you have to take a pregnancy test first, and then not only that, he said, that if everybody takes a pregnancy test, they get the first vaccine. Some people don't know or didn't turn positive yet, so they made them retest, and if they were pregnant, they kicked them out of the study. But they were then able to just see, okay, well, if 3% got pregnant after the first, there's our convenience sample. We'll just see how they're doing. So I think we have to have a better, we have a responsibility for having more data, for medication use and vaccination safety for pregnant women. We need to have some way to make that the next, because it's a huge gap in knowledge.
So the CDC does have now a really large pregnancy registry for the COVID vaccine, the mRNA vaccines. And they came out 18 months later and found that it was safe to take during pregnancy, because if women did not take the COVID booster, if they got COVID, they had a 50% chance of going into the ICU and going on a ventilator. It's the same for influenza. And we have decades of data that the influenza vaccine is safe. So the Zika, remember Zika? When it came, the Zika vaccine, no pregnant women in that vaccine trial. So it just seems preposterous, right? So we as women, you as brilliant, wonderful women, need to start calling this out to your physician, advocating, asking why. Talk to your state representative. We need change to happen.
I wanted to bring this up because I think it's even larger than we realize. And I think that when you think about our design of our world, So this is, representing a car crash, obviously. And as an emergency physician, I really understand how critical, how life or death or limb or just the harm that something like that does. And so now if I were to, so there are 6 million motor vehicle crashes in the United States every year. And if you're a woman sitting in the front seat versus a man, you are 73% more likely to be seriously injured and 17% more likely to be killed than if you were a man sitting in the front seat. And so when you see something like that, you think, well, how come? How is that even possible? It's because the car manufacturers are designing their cars to pass safety standards. So then you go look at the safety standards that they're building it to pass, and those safety standards are created and developed based on a 70-kilogram male crash test dummy. Women sit closer up to the dashboard. We have wider pelvic girdles. Men have stronger neck muscles, so they are able to withstand whiplash, right? So even the design of our world can really affect the bias in it, can really affect our health. If I were to ask you to picture what a CPR mannequin looks like, you're all picturing a white male torso, right? So then if I were to say, women are less likely to receive bystander CPR than men, would you be surprised? Right? There's no mental model for what that looks like. What do we do with the breasts? What if someone, everybody's afraid, what if someone's gonna, I'm not touching that. Right? And even just, my personal protective equipment during COVID, when it was really, really frightening for me. I wore men's small, because that's what I've always wear, right? I wear men's small gloves, men's small, N95. I have a totally different, facial structure. My booties that I was wearing were meant for a men's size 15 shoe. I was taking tape and to make sure I wouldn't trip over it. So I think just, bringing those pieces into your head. Again, we're going to end on a positive note. I promise.
Yeah.
I promise. But this sort of eye-opening, I think, is important to be shared, because this is really, where we're going to make the change.
So I will say that we have a lot of really big health systems. You have big health systems here in Dallas that take care of hundreds of thousands of probably millions of patient visits. And so the benefit of having these big health systems is that we can now look at the data by men, women, male, female. And so big data in healthcare is here to stay. And they listen, because you heard I was the chief academic officer for Prisma Health in the upstate of South Carolina. Prisma Health is our largest integrated health center. It covers 2/3 of the state, one of the unhealthiest states in the country. And because I've been there for 4 years and I do talk to the leadership, and Alyson is now there with me, we've started talking to them about looking at the data, reporting the data, lowering safety events, adverse events for men and women, because what does the CEO wake up every day thinking about? Right, not losing money and days of cash on hand and their margin. So if you talk about it in the ROI, we can't just say, you should do this. Remember the words I told you really don't get people to do something? Should, would, or could. But if I tell them, you are misdiagnosing women with heart failure and they are coming back within 30 days to the ER, and you are making $0 because of that bounce back within a month, I got their attention. When we don't diagnose women with obstructive sleep apnea, you only have to ask yourself, or if you sleep with someone, ask them, or turn on an app on your phone. If you snore and you're tired in the afternoon and it is different for you, go tell your doctor you want a sleep study instead of letting them give you a thyroid test, a blood test, and then tell you that it is all, and try to give you Prozac or one other antidepressant. And I always say that something that an antidepressant will not cure is sleep apnea, and something that Valium won't cure is a heart attack. So when they tell us that it's stress. So empower yourself to speak up and to ask those questions. Don't settle. So if I don't get good customer service at my vet's office for my 2 puppies, I change my veterinarian, right? If my mechanic doesn't fix my car, I go to a new mechanic. And yet we continue to go back to providers that we know are not listening to us. You don't have to do that. You can change your provider. And you can go in prepared for that discussion. We wait months for our doctor visit, and then we get in there and we have 7 minutes. You have to use those. You have to speak up and speak out. And don't let them throw something at you and run out the door. Like, you can ask questions about that. So we go to the next.
This is our second to last, and I love this because when there's just always been images of men in sort of the, health and medicine, right? So, and then I look at this and I'm like, this, bouncing off of what you just said, we have the ability to really take charge of our own health. I think that we have to stop looking at it as siloed organs, right? And as us as a whole individual. I think that, like my national collaboration that we're in with all the different health specialists, I think that that's really important because then we're having that crosstalk. I've been encouraging, I just gave a talk to a large group of obstetric and gynecologists, and I told them all about when they're discussing that pap smear result, to ask them, oh, by the way, you had gestational diabetes or you had hypertension during your pregnancy. Do you know that you have higher risks of heart disease? Right, because we're looking at even maternal mortality, which is really high in the United States. It's getting higher, and it's a frightening statistic. But when you think about what is the #1 cause for maternal mortality, it's heart disease. So we all own women's hearts. I think we have to really sort of have that empowerment, that understanding, asking questions of your doctor. Oh, thank you for that prescription. Is this the dose that I should be on because I'm a woman? I had a hysterectomy. I don't have my ovaries. Should I take a different dose? How does this affect my birth control, my menstrual cycle? Because we've shown that it happens both. The medications that you take can affect your menstrual cycle, and your menstrual cycle can affect medications that you take. And so these should be really, conversations that you have. And your doctor may not know the answer at that time. And that's okay, because that is now you are emphasizing where your sphere of influence is. Because that doctor is going to say, good question, let me look it up. And then now they'll have that information. And if they don't respond in that way, then it's time to move on. One thing I think is really critical since the pandemic is that we have this ability now to have telemedicine. And so you're not stuck with who you can access, who can you drive, 10 minutes. I've had that doctor forever. I know, he or she stinks, but now it's like, wait a minute, no, I deserve better. I want to go to an expert that knows the difference, that can have this discussion with me. The Laura Bush and sexandgenderhealth.org, the Laura Bush Texas Tech University Health Sciences, website, I talk about, I use it all the time. It's such a wonderful resource for students, for physicians, for just, you know, anyone just wanting to read up and look at the questions. And there's a PubMed search tool that you can use to look at the literature yourself. There are so many resources there, and I think that I'm so grateful that that exists.
I've encouraged you to empower yourself, Alyson. We've encouraged you to do that. We have information about many diseases now that we did not have 30 years ago because women signed up for research studies. So maybe we don't have exactly what we need on the data, but we have more data. We have advances. Women still live longer than men. We are seeing more female animals being required to be studied. The NIH now requires all researchers who get money to study both sexes of animals or tell them why they won't do that. So if it's prostate cancer, for example. So we are moving toward that. I think the more that we marry healthcare delivery systems instead of siloing research at universities and academic centers, and we start really merging that and integrating research into our big health systems like Southwestern, Methodist, et cetera, that's where more data is going to come from. And the more I actually am in a clinical trial myself, and they asked me to participate, and I thought, yeah, I'm going to do that. I encourage women to do that. I should do it. It takes a little time to do the follow-ups, but maybe it'll give a woman, I'll pay it forward and give her some answers. So as we go to the last slide and then open for Q&A, I will hand back. You want to talk about OM?
Okay, yes. So I think, you know, Marjorie and I haven't been doing this for so long, and I've worked so hard in the research realm and you know, education realm now, and we're being much more solution based. That's what we need, right? So we want to raise awareness and empowerment, and then what else can we do to improve the situation? And so we have started this company with the CEO, Anka Griffiths, who's here, and it's called OM, and you can see it on omexperts.com. And we've created a personalized medicine platform. So we have all of these experts. Remember I said I want to go to someone that knows the difference? And so this may not be, you know, the goop.
Right.
Yeah, you had mentioned.
Goop and
Yeah.
Poosh. Is Kourtney Kardashian?
Kardashians, gummies, vitamins. Elemi, yeah, exactly. Yeah, so we want to make sure that we collect the real experts that know these differences and can really help women to know what to do. So creating master classes that'll be available. Our first book that we put together with our publisher, Brina, thank you. Please also feel free to take a book, take one for your friends. We're happy to share that with you today. And we've been working with corporate companies to really improve the type of employee health that's being delivered. So we're very excited for this, and we are devoted to it because it's devoted to this issue.
And I think we can go down the rabbit hole on the internet, right? I mean, there's a lot of information out there. You don't know who's really telling you things. Do they really know what they're talking about? I think I've never really gone into an outside entity like this, but when Anka came to us with her vision, I felt like this is the right thing to do for women. I'm in the latter part of my career. So what do I want to leave behind over the next few years? And this meant a lot to me. It spoke to me. And Alyson and I are the scientific experts. And I trust Alyson. She trusts me. And so we're building this. And think of like Huffington Post in the early days, right? What if there was a site where you could go and listen to a master class or get a consult? So the book, why aren't women winning at health, or women aren't winning at health? This book is not a lot of research and a lot of heavy discussion. This is about what we as women are conditioned to do by society, by thousands of years of culture, and how we react to things and how we can take back control of our health. And each chapter is written in one of our different voices, sometimes all three of us, and it tells you whose voice is talking about that. And sometimes it's very raw. That book in some places is really, we spoke from our heart. We spoke very vulnerably, because we want you to see that that's okay, even from experts, that you're able to do that. So I'm going to end by saying one thing that really ticks me off right now is how physicians are gaslighting women. I mean, really telling you, you don't know your body as well as I know your body. Really? So, and because you can't diagnose it, it's nothing. And women are being misdiagnosed and having brain cancer, colon cancer, other symptoms, the syndromes. We now have long COVID syndrome. Guess who is the majority people who are impacted by long COVID? We are. So I'm going to stop there because we want to have Q&A. And also, there's some really hot topics out there that I think you guys probably want to ask about, like Ozempic and Wegovy. The buccal fat removal procedure, which is really hot on the internet right now by influencers. So really, why I say that is there's no topic you cannot ask about. This is an open floor for you guys.
Does anyone have a question? Oh, is this hot?
So all medicines go through a safety study with pregnant animals at the FDA already. And so if it causes any adverse reactions in the fetus, then they give that an X. So what I'm saying and what I ask the pharmaceutical companies to do is, if you've enrolled a woman and she gets pregnant and she wants to remain in that study because that's a life-saving drug for her, let her stay in. Because and if a woman is taking a seizure med or an antidepressant, and she's going to stay on that medication, let her stay in that study. What they're doing is they're taking away our right to say yes to research. And I do think we absolutely need that tort reform. But no, I'm talking about getting women. You know what's so easy though? Lactation. If I'm having to take a medicine for my blood pressure and I'm breastfeeding, or I want to breastfeed, they can easily test the level in the breast milk. That's like low-hanging fruit. Why would you not do that?
Right, they do that with alcohol. You know, when women are breastfeeding,
Pump
they
and
have
dump.
kits where you can test right, the milk for alcohol. So why couldn't they do that?
Exactly.
And normalize that. That makes a lot of sense. Speaking from experience. Maggie.
Well, my daughter-in-law, not this one, just got a brand new doctor at Baylor. And she goes in, she's not been at Baylor system at all. She goes to fill out her form. There was no sex line. It just said gender preference. So once again, women are going to be not what you're saying, the big health systems are going to be earning future research, but we're not going to know what it's literally only said gender preference.
Gender preference.
And my girlfriend is an oculoplastic surgeon, said she got the directive from the state that said, quit asking, well, if they were gender. So
That's a really hot button issue too, obviously, here in Texas. What do you do with that medically, the gender preference?
I'm in the baby Texas, so I'm from South Carolina. So very similar. I would say that just a reminder that sex is your biological variable. That is the hard science. That's your blood testing, your physiology, your anatomy. Gender is a social construct. So gender is a spectrum, and the way gender impacts our health as women is the biases of how the environment is biased against us because we present as women. And so by doing that, I totally agree with you. I think there's going to be massive deficits in finding answers if big health systems like Baylor go to gender preference and not your sex at birth. It's not that hard to ask sex at birth, right? I mean, we still ask all those questions at Prisma Health. And if they moved to that, that's when I would be talking to my legislators in Columbia, and I would be talking to the CEO of the health system and the dean of the medical school, and say, this is going to harm people. It's going to harm men and women.
I think also keeping in mind that those two words were used. They're not interchangeable now, but the evolution of the terminology has really evolved. As a physician, when I look at literature, research, I look to see, okay, I think about my patient, and I think, okay, what is the biological sex of my patient? So I know what chromosomes are in their heart and liver and things like that. And then I look at the research for that particular sex. But we're also starting, the United States is a little bit behind, but gender issues. And gender, it's as we said, it's fluid, but it's also something separate to study and to figure out. And then I can pick from that research and individualize my care of my patients. So I think we're getting much better at realizing that we need to know both of those aspects. But then, of course, it carries with it some of the political issues around the pronouns.
I'm surprised Texas would go with gender preference, to be quite honest. That seems so like West Coast to me. So
Times are a-changing.
Yeah, so if you do have any connections, Mrs. Bush, do you have any connections at Baylor? If you do, please
make a phone call.
Make a phone call. Give them my email. I want to talk to them about that. Baylor's a huge research infrastructure. We cannot. This is a bad idea.
Yes, thank you for mentioning that. On our website for OM experts, download a form that you can fill out. So you can really it's just going to take one time for you to really sit down, and we ask the right questions. What is your biological sex? How many conditions happened during your birth? What CAT scans have you had recently, and what the results were, or what surgeries? So I think, having that, you could fill it out, you could take a picture of it, you can import it, and so when you go to that new doctor, you can say, these are the things that I think are important for you to know.
And we have the Know Your Numbers, right, from the Laura Bush Institute, that has the right range for your blood pressure, your cholesterol, your blood sugar, all of those things, and it's just a little laminated card you can put in your wallet, reminding you to know your numbers. Don't depend on a physician to tell you what's good or bad or, needs a medication. Like, take control.
Mm-hmm.
More questions?
I have a question in the back, right? If you could stand up so we can hear you.
Hi, I'm Jenkins. I work for the Alzheimer's Association, and I'm embedded here at Baylor AT&T Memory Center, which is a dementia research clinic. Do you all foresee a day and age, because we are in such an exciting time with actually having treatment now for Alzheimer's in particular. Do you foresee a day and age that we will have women's health providers actually doing screening as we all enter the lovely menopause and postmenopausal age? Because we know that early detection
About 30 to 50% of women in any city use their OBGYN as their primary care, which is, I think, why you're asked that question as well. Usually, the United States Preventative Task Force tells us what to screen for. So we need that data and that task force to tell us that if you will screen women and men for memory loss at an early age, you are going to be able to slow down the path of Alzheimer's. And if that happens, usually that's incorporated into your healthy physical. I know we have the Brain Institute here in Dallas. They do baseline brain health physicals, which is so important because this thing about menopause is causing me to be forgetful. We got to stop that. Like you may start having, we know women have loss of memory in their 40s. Like we have early onset issues, but it seems like menopause makes us more aware of that. So I would love to see that in screening, and I think that's important. And at the same time, Alzheimer's is almost a women's health disease. Like 70 to 80% of Alzheimer's patients are women. The new medication, which slows down the rate of advancement of memory loss, could keep someone in their home for months or years, depending on when it's implemented. So this is important. And I'll take a look and see what the U.S. Preventative Task Force says about memory screening and at what age. But I think we should be doing that. And you could ask your doctor to send you for a neurological memory study. If you feel like you're forgetting more often, you can just ask them to refer you to a neuropsychologist.
Research studies that somebody has an autoimmune disease, and thank you, Deep Hawk, for inviting me because I know she cares about my health. But one of the things I look around, we're mostly women, in leadership positions at legislatures, people passing policies, the would, the could, the should, the people that think with the must, that have to, that you will be fine, are mostly men. So as we talk about, political topics and controversies, what would you all advise us? What are you all doing? What is the Flora Bush Institute doing to ensuring that the rooms full of men are taking charge and are being our champions, because they're the ones with power right now. We're changing them. But how do we do it in any, like you said, like the CEO, how do we tell men this matters to you and in which they understand? Because clearly it doesn't.
So I think that we have one-sex diseases. So when I talk to groups of men or leaders, it depends on what I think is going to get their attention the most. So men usually have at least one or two women that they love a lot, like daughters, friends, sisters, mothers. Talking about that and why it's important to them. Pardon? Why? Oh gosh, I didn't, did I? I've been married 31 years. I hope my hubby still loves me. So I think that, so I'll talk about money and ROI. I'll talk about who you love in your circle and why this is important. And I also tell men that you are being disadvantaged by a medical system that is one sex and gender blind. Now, why do I say that? The worst diagnosis that a male can get is breast cancer. Number one, they're underdiagnosed. The FDA medications have not been studied. They're treated with women's medications. More often than not, they're told men don't get breast cancer. When you have urinary issues with men, it's always the prostate. Not true. And yet the poise pads and Depends are over by the feminine products and depression. We know men present differently with depression. They get angry, right? They use drugs and alcohol more often. And so I will give them science that this matters to you too. Sexual dysfunction as well. So you just have to kind of think about, if you're going in to have that conversation, what's going to really get their interest. And you can, and we do have more women in Congress now than we have. And one thing that's sort of been, with all the bipartisanship and everything that's going on in our political arena, we haven't galvanized the Women's Congressional Caucus and really gone back, because it was them that made that 1993 Reformation Act happen. It was women congresswomen that made that happen. We need them to be there for us again. So all of that, I don't know if that answered your question, but there's some different approaches.
A quick example in emergency medicine, because I also just data, like looking at the science, and when things are looked at, when biases are actually proven, I find that to be very helpful, because I just say, well, it's not about you anymore. It's just about good science, right? So if you show them that, when we actually look at this, there's this difference. Well, that's all it takes. It's more rigorous, reproducible science. And this one study looked at women who go to the emergency department with a heart attack, and they had lower probability of survival if their doctor was a male. And so that alone, right? You're like, why? Like, what's going on? What's being missed here? But what was really interesting about that study is that the men who worked with other women colleagues did better at caring for women patients than the men who didn't have women colleagues. Mm-hmm. And so it's this, we have to become diverse. We have to get ourselves on that board. We have to show them that this is just, these are real issues that we would all need to want to do better at. So I use the evidence and really shoot for diversification.
I want to ask, because I saw a lot of eyes light up when Dr. Jenkins mentioned Ozempic and Wegovy. A lot of people are shrinking in our community and getting really skinny on these drugs. Tell us about these drugs, if they're safe for women.
Oh, so yeah, so they're mostly for diabetics. Wegovy has been approved for weight loss in women and men with other risk factors for cardiovascular disease. So they are not cheap. They're $1,500 to $2,000 a month, once a week injection, and people are paying out of pocket in order to help them lose weight. So we don't have enough data yet on what is that utilization. Remember Fen-Phen? Anybody old enough to remember? I remember Fen-Phen. And women took it, and it was this really successful weight loss drug. You would lose weight on phentermine, but it caused your mitral valve to get floppy, and women had to have heart valve surgery. So I would say that we're gathering data. Of course, it's a multi-billion-dollar business, and so the Ozempic is going to go for the same weight loss, and then there's a newer one on the market. And so, yes? No. These are prescription medications.
Can you talk about those two, because that
Yeah.
pops up?
The gummies? No, they're not. If gummies could help us lose weight and be skinny, would we all not be popping gummies every day?
Are you talking about keto gummies, I guess, that are being advertised?
Oh, to go with your keto diet?
Probably.
Which is all protein, no carbs, very restrictive. Again, restrictive diets don't work long term because you can't restrict forever. And so the new healthy eating mindset is, most of the time, the issue is our relationship with food. It is about our like, oh, that's bad. I can't have that cookie, or I can't have that cupcake. That's bad for me. When really it's not bad for you. 12 cupcakes is bad, I mean, so we, and I think especially for us women, what I've heard from some colleagues and even some patients who have used Ozempic and Wegovy and are losing weight, is that it's sometimes our mind perseverates about food. Like, I wake up today, I'm going to start a new diet, the Monday diet. We think about food. We think about what we're going to eat. We feel guilty if we eat something we shouldn't eat. And it stops that persevering. And so they don't think about food all the time. It also it can make you nauseated, so you don't want to eat. It causes a lot of GI side effects for women. But women are using it because they are losing up to 20 to 30% of their body weight. Now, we don't know what happens when they stop paying $1,500 a month for Wegovy or Ozempic. And I will tell you that we do know now that obesity is a chronic illness. You have genetics for obesity, and we have to start thinking about it, such as it's a chronic illness. I may need to be on this medicine my entire life if I don't want to be obese or I don't want to be overweight and increase my risk of stroke and heart attack. And if a woman asks me, should they try Ozempic or Wegovy, and they're overweight, meaning your BMI is in the obesity range, or you're overweight with a risk factor, I would tell her to try it. If that is something that is troubling to her so much that she wants to take this injection every week, then I would say to try it and see if that will help you. It even doesn't work on everyone. Some people gain weight on Ozempic and Wegovy. So Mounjaro, and there's great data. Mounjaro is even the third generation, so that's going to be even better. And I think that what people are thinking is, oh, I can just take this injection and I don't have to change my relationship with food and my dietary habits. But you have to. You must do that. And so I think it's promising, but we don't have long-term safety data.
Okay.
I just wanted to thank you. This is great. I have two, I hope, encouraging comments or questions. One is, I'm sitting in this room and know a lot of people who have daughters. My daughter's age 30 years old, so they're either married, getting married, but they're using birth control to your earlier point. And this whole conversation, I just thought, I'd love to know what you're doing for the younger generation. How are you reaching them? Because I think it would be so much better for them to hear about what you're talking about now, as opposed to me, who's, I'm enjoying it and I'm using it, but mostly for heart disease and, I guess weight loss and whatever. But I just wondered about your outreach to that generation, to the, 18 to 40-year-old crowd. And the other thing I wanted to just encourage you is on this tort reform, because even Maggie's comment about the form that her daughter-in-law filled out, the tort reform, Texas is a great place to pilot tort reform on this. And I know you were speaking to the federal tort reform, but Dick Weekly with Texas for Lawsuit Reform, a lot of people are interested in tort reform in these areas. So I would encourage you to think of it in a bite size, which would be try it in Texas and see what happens. Because I think this is just amazing information. Thank you for being here. But I hope you'll figure out a way that we can give our daughters an app, because that's the only way they learn.
Well, I've never heard Texas called bite size before. I'm just going to say that. But I agree, and I think Texas is a great state. I lived here, raised my family here. I love Texas. I would say that about girls, we know that we're not reaching college-age women in relation to cardiovascular risk reduction. The prevention of heart disease starts in puberty. So when half of our new onset diabetics are under the age of 18 in this country, we have a problem there. So I do agree with that. And I know that the Laura Bush does outreach to college-age boys and girls, men and women, and we need more outreach. And I don't know about apps around physical health or oral contraceptives, but I do know that oral contraceptives are very safe long-term for young women, and that there are great benefits to them as well.
And then just one comment is that both Marjorie and I have published a medical textbook, and so we were always science and textbook and teaching. And then we realized, right, things aren't really changing when I go to my shift, right? So that was the inclination for the books, really. So my Sex Matters book, and then this book that we're showcasing today, is meant to just go out there and to spread the word, you know, organically with younger women. So, you know, we're hoping that helps.
To be influencers in a way that we haven't really elevated women's health and sex and gender medicine to where it's mainstream. And you do that now by building a platform and people wanting to hear from you. So more in this book series, why aren't women winning at cancer? Why aren't we winning at heart disease? Why aren't we winning at sex? Like, I could spend 2 hours with you guys around sexual dysfunction or sexual function, about, you know, the imbalance around that for us as women. So there's more to come. And we are advocates. You guys can all be advocates as well. I don't live in Texas anymore, but I will gladly talk to any of the congressmen or women to talk to them about the importance of these issues.
Did you have a question? Oh, I saw your hand raised. How about you? Yes. Can you stand up so we can hear you? Thank you.
I have a question about, as far as spreading the word goes, is going into the medical schools. I mean, such a larger percentage now of our rising doctors are female, so there's, I hope, a receptive audience there. But who's in control of medical school curriculum, and how do you get in there? And I feel like you're rolling your eyes.
I'm not rolling my eyes. I can tell you, before I was the dean of a medical school, and now that I am a dean of a medical school. So before I was dean of a medical school and we built the Laura Bush curricular resources, we built that and open sourced it to the world. So people could download and integrate into medical school very easily. And we still are the global leaders in that realm. Now that I'm a dean cannot mandate that you teach sex and gender, but they knew their dean was a sex and gender expert, so they're putting it into the Greenville Medical School curriculum. But also the national coalition that we have helped to grow is getting this into dental schools, pharmacy schools, nursing schools, and medical schools. And I led a survey in 2015, and we had over about 1,200 medical students answer the survey. And we had representation from every medical school in the U.S. And we are now just launching a repeat of that study. So we can send that back to Connie Tyne and let her share that with you at your next coffee and conversations, maybe what that data is showing us now. What our survey showed us in 2015 is that 96% of medical students felt it was very important to be taught this. And that it was important to them in taking care of people. And so I think this new generation of learner, millennials and Gen Zs, are very aware, much more than we were in medical school, about differences between men and women and the importance of that, and also the gender spectrum. So I suspect we're going to see really much better data around how many schools have incorporated this into their curriculum. I can't wait to get that study out. And actually, one of my med students is helping with that research, so that's exciting.
I was just going to add to that is that it's all about the accreditation bodies, right? When you mentioned the Alzheimer's screening and how it has to come from the U.S. Preventative Task Force. So a dean can't just change the curriculum, but the accreditation bodies could, you know? And so we have to think about where do we have to access to enlighten them to be able to change and to mandate. So, you know, those tracking it back to that is something we've talked about a lot.
And new news over the past week, the American Association of Medical Colleges is actually forming a task force around curriculum on sex and gender in medical schools. Several of our colleagues are on that task force. And I just found out 2 weeks ago that back in 2001, when the Institute of Medicine wrote a big report around sex and gender and why sex matters, they've now formed a new committee at the National Academies of Science, which is the new name of IOM. And I met the chair who came to speak at our school, and we sat and talked for an hour about their new committee, and she's invited me to come speak to their committee about a framework to measure that we're making progress, real progress in women's health. So really, I see more activity that I think is going to move this needle in the past few weeks than I've ever seen in my career.
Yes. Yes. Yes, ma'am.
I want to add to your history. My late husband graduated from Harvard Medical School in 1970. And one of his classmates was Dr. Bernadine Healy. And she wrote a book way back when, Bernadine Healy, MD, Getting the Best Medical Care in a Man's World. A new prescription for women's health. So this fight has been going on.
I am so in awe of Dr. Healy. She was an amazing woman. And so you see, in 1970, there it goes. But we didn't have, back in the day, we didn't have the internet and social media and social platforms and information right at your fingertips that you can search for and get answers to. And I think that's going to be a game changer for us. And I would love to see us, to your question about young women and men, I would love to see us activate some of these TikTok influencers to really carry a message and be advocates, because they have a powerful following. And so we need to engage and activate the Gen Zs and the millennials.
Yes.
Karen Kelly, I've spent the last 20 years in drug development, working in healthcare systems, right, enrolling clinical patients into clinical trials. I know the data for women exists, and it has for a really long time. My impression is that it's going to take the FDA regulating that the data actually be utilized for indications and for dosing, right? So is that do you agree? What do we have to do? What do you think is going to be the
So Congress needs to empower the FDA to require that. So the FDA only gets the power that Congress gives them with congressional mandates. And they've been given that power over certain areas, but Congress needs to give the FDA more authority. And I told you NIH has a $49 billion budget. FDA has a $6 billion budget. And the rest of their funding comes from pharma. So if that's not a conflict of, I believe the FDA has absolutely got the best scientists. I don't think they're influenced by those user fees. And at the same time, shouldn't we really uncouple that and really fund the largest public health agency in the world to the limit that we need to? And another reason pharma won't disaggregate that data and report it is because of this. I'll give you a quick example. I'm studying a stroke medicine. It prevents stroke in men 10 or 15% higher. It doesn't prevent stroke in women, or maybe causes an adverse event. But I pull all that data together. Who's more likely to be enrolled in a clinical trial for stroke? Men. So there's more men at positive data. So now the data looks not as positive, but still positive. So if we disaggregated it and reported it out, they would lose half of their population. That would not bring them billions of dollars. So you follow the money, and that's really where we need. So we do need Congress to act and give FDA that authority.
Any other questions? Yes, ma'am.
I have one question for you. You gave us the example on the engineering and
Yes. The first moonwalk that had a woman, the first space travel that had a woman, she was not able to get outside and do any spacewalk because the suits that they brought were for men's bodies. That's number 2. Number 3, not maybe about design, but once a woman is in a traumatic car accident, she's less likely to be airlifted to a level 1 trauma center. Now, why is that? But yet that is true. What else have we seen? Oh, the hip and so like help my husband, right? Help the guy. Devices. So FDA devices for heart failure used to be too big to insert into a woman's chest. And so they had to wheel around a device. And hip and knee replacements as well. There's been some real data around how hip and knee replacements may not be exactly along the lines of the anatomy a woman needs, because who designs the technology genders the technology. Why do you think women have so many typos on their iPhone? Because 98% of software designers are men, and the pressure that we use to type doesn't always work the same, and our fingertips are different.
There was a study on smartphones, and it compared, Android, iPhone, and they asked it questions. So there were like hard questions and then female type questions. They call them different. So they said, "Hey Siri, I'm having a chest pain," and Siri would say, "Would you like me to call your doctor's office? Would you like to know where the nearest hospital is?" But when they asked it women-specific issues like, "I was raped," or "I'm depressed," they essentially had no advice at all. And they traced it back to who writes the code for those things. And if we are still male-dominated in STEM fields, then that trickles down the bias. Yeah, they for that particular study, it was just "I'm depressed," and so I think they were considering that women are probably more likely to be open about it than men.
And the designers probably didn't think about depression as a major health issue because they were men.
Right.
And I think that, and remember, artificial intelligence, which is blowing up right now, and artificial intelligence actually, it is based on real world data. Like, they don't just go out somewhere in the cosmos and get data for artificial intelligence design. It's real data. And so if you have biased data in, you're going to have biased data out. And who in this room has said something and Alexa will not do it? And when your husband says it, she does it. I am not kidding. And I just said that to another couple, and they have the same issue. I say, "Turn on the lights in the great room." Nothing. I mean, my husband says it, and I think it's actually just the tone and the octave of his voice. I think that actually makes a difference with Alexa. And I also think Alexa's learning, and she's getting to be a little smarty pants as well.
We probably have time for one more, Jean.
I just wanted to make one statement about the Marjorie Institute for Women's Health. It certainly is not anti-men. It's done the best job of pointing out the differences and discrepancies. I know just since I became involved with it, I asked my doctor, were these clinical trials done on females when they prescribe something? Should I get the same dose as a man? Why does my husband get the same size flu shot that I get? I'm half his size. So I think what the Laura Bush Institute has done for me is make me advocate in a different way with different knowledge. Car design, I don't know about that. But the Laura Bush Institute has really made me look at my doctor's visits in terms of a different kind of health. And they've also done a lot for men because they point out the differences, so.
Thank you, Jean.
Yeah,
That
that's
is
a great point.
That is so great. And at the beginning of the Laura Bush Institute, I was told that we needed to study pregnancy and endometriosis. And I said, you've got the wrong girl, because I'm an internist. And sex and gender is really where we need to make a difference. And then a few years later, when Laura came to Lubbock, we were putting out a press release, and they couldn't reach me, and so they changed every sex and gender term in that about sex differences to women's health, which put us right back to the 1970s. And so I actually offered them my resignation that day. I said, if we can't use the term sex and gender, and we're building this institute under the First Lady, we've got a problem here. So a lot of the Laura Bush Institute, again, just having Laura's name carried so much weight that we were able to build this from Texas. That is a big deal. So I've just had to share that.
Yes, thank you. And thank you so much. We want to make sure
Thank you
we're
all.
respectful of your time. I want to remind you that the Laura Bush Institute is a 501c3, so we would love your support. Thank you for those of you who already have supported us. Thank you to the National Advisory Board, especially you two, for supporting this particular conversation. And get involved. We've got their books also in the foyer there, so have a great afternoon. We hope to see you again
Thank
very
you.
soon. Take care.
Thank you.